the characteristics of flurpiridaz, and why it's going to benefit. Again, we have the same disclaimer. I have to display it. I do work for GE. I'm not going to read the whole thing, but you know the information on there. Use your own judgment, and if you want to follow up on that link, all the information is there. But there's a statement that was put out in conjunction by ASNAC and SNMMI. ASNAC is the American Society of Nuclear Cardiology. SNMMI is the Society of Nuclear Medicine and Molecular Imaging. So this statement is very important because it puts out a couple of things and then some things on the bottom. But the first thing that I want you to look at is that PET-CT, cardiac PET-CT, should be the first line preferred test. Whenever you have a patient that either has been diagnosed with CAD or is suspected CAD, your first line preferred test needs to be PET-CT, cardiac PET-CT. There's no question about it. And we're going to talk about why it is. But also what they said is there's no clinical scenarios where PET should not be considered a preferred test. So whether it's epicardial disease, whether it's microvascular disease, multivessel disease, metabolic changes, whatever you're concerned with, there's no clinical scenarios where PET-CT should not be the recommended first-line test. So it's very important to understand that. But also, they came out and they said, well, there's a group of patients that are going to benefit the most from flurpiridaz and from PET-CT. And that's what the bottom we're going to talk about here. The first one is you're going to have patients that maybe they had a functional test done. Maybe they had a CCTA or they had some kind of imaging and it was inconclusive, or you couldn't, figure out what it was. Well, if you had a patient that had prior testing and it was inconclusive or non-diagnostic, or, whichever way you decided to read it, that is a prime candidate for cardiac PET-CT. The second group of patients is patients with certain body characteristics. So we're talking about patients with obesity, females with large breasts or breast implants. And when I talk about breast implants, keep in mind, we could be talking about male or females. And I like to point out when we talk about large breasts, it could be male or female also. So we need to, keep that in mind also. Or patients that had, chest wall deformities. These are perfect candidates for flurpiridaz because of the quality of the image that you're going to get is going to be better than any other functional test out there. And then you have your high-risk patients. High-risk patients, you want to make sure that, there's no errors on how we're reading the test. And we're talking about patients with like chronic kidney disease, patients with diabetes, patients with multivessel disease. And when we're talking about multivessel disease, I like to focus on balanced ischemia. Those are patients that if you miss that diagnosis, it's not going to be beneficial to the patient. So these patients are going to benefit a lot from cardiac PET-CT. And then the one that I really like is young patients. Whenever you have a patient that is, let's say the patient's 35, 40 years old, and the patient has been diagnosed with CAD, ASNAC and SNMMI say that patient should be having cardiac PET-CT. And we have to think about why. Because once the patient's been diagnosed, and most people do it differently, but when I was doing it, if you've been diagnosed with CAD, we would do every 5 years. We would do a SPECT. Every 3 years, 4 years, depending on your history, depending on your, have you had any, any bypasses, any cath lab work, anything like that. But let's say every 5 years, you just want to check up on the patient and make sure everything's okay. Well, if you're going to do a SPECT on the patient every 5 years versus PET-CT, keep in mind that when SPECT, you're giving the patient twice the radiation almost. So that's going to make a difference in the long run, especially if the patient is young. The patient's going to be around for another 60, 70 years, hopefully. Well, that's going to make a big difference if you're doing that every 5 years. So that's why your first line should always be cardiac PET-CT. And then you have patients in whom myocardial blood flow that you can quantify are going to benefit from it. And we talked about it, multivessel disease, microvascular disease, or improved risk stratification. Those patients benefit a lot from cardiac PET-CT. And then there was another statement that was put out by SNMMI, ASNAC, the European Association of Nuclear Medicine, and this is specific to flurpiridaz. So they talked about clinical indications, and they talked about clinical patients with both, if you look at that, symptomatic and asymptomatic patients. And we really need to understand that there's times when you're going to have a patient that is asymptomatic, but appropriate use criteria says you need to do cardiac PET CT on this patient. Being asymptomatic, there's times when you really need to take a look in there. And it's patients, with the high risk population, patients that, have a high risk, greater than 20% over a 10-year risk. And then those patients, you want to do testing and it's warranted. But also patients that are symptomatic, intermediate to high, obstructive CAD, risk stratification, and specifically microvascular disease. But the one that I put a red circle or a red square around it is absolute quantitation of myocardial blood flow. And if you're not familiar with a quantitation of myocardial blood flow, that's basically your MBF and your CFR, your coronary flow reserve and your myocardial blood flow. And what that tells you is we're not looking at the epicardials, we're looking at the microvascular. And we can pinpoint it either by blood vessel or by your 17-point section, however you want to do it. We can pinpoint it and tell you where the microvascular disease is located and how severe it is. And flurpiridaz is the best agent for that. It's the best agent because it has certain qualities that we're going to talk about that are going to give you better results on it. So we talked a little bit about choosing the right type of imaging that you want to do. This one right here, I hope you don't expect me to read all of it because I'm not, but it gives you an idea that in reality, they all have benefits and they all have a little bit of disadvantages also, all of them, even cardiac PET CT. And it's very important for you to understand what are you trying to accomplish, what are you trying to find out, and that's going to help you decide which type of test we want to do. Now, our goal is to expand knowledge about cardiac PET CT, but we have to remember that ultimately we're patient advocates. So our goal is always going to be to do what's best for the patient. And that's why we put this here, because we understand there's going to be times when you might want to do a CT with FFR, and that's okay. If that's what you think is best for your patient, it's completely understandable. And this is just want to give you an idea, of what the advantages and the advantages are. And there's times where you just want to do an exercise ECG, no imaging. Absolutely understandable. So just keep that in mind, and it just gives you a better idea of what we're looking for. And then I just want to touch lightly on the journey of flurpiridaz. Flurpiridaz has been approved by the FDA, and I'm going to tell you, there was a lot of excitement, in all over the U.S., especially, I live in Houston. We have a large medical center over there, and there was a lot of excitement. And we work with them, and it's going great. And a lot of places are doing it constantly, regularly, and we're getting great results. But a lot of people don't understand that this journey started in 2007, almost 20 years ago. So it's a long process. We had to do phase 1, phase 2, phase 3 trials, and it used to belong to Lantheus. We bought it from Lantheus and we put it out. And then so on September of 2024 is when the FDA gave us approval. And it was a slow process. Just because you have approval doesn't mean everybody's going to jump on it. It's a slow process, and we want to make sure it's done slowly and appropriately. But our goal is to, bring it to Puerto Rico and make sure that all the patients can benefit from this also. And you can make the decision. If you want to do a calcium score, do a calcium score. But if you want to do a cardiac PET CT, then you should do a cardiac PET CT also. So that's our goal with this. And just to touch lightly on the clinical trials, it was the Aurora trial. It gives you an idea what the population was, what the endpoint was. We had a standard of truth, and it just gives you a little idea. The standard of truth was, in this study, the presence of CAD. Can you find it? Can you localize it? Can you quantify it? And we tried on the study population, we try to keep it pretty balanced. So we try to do patients over 65 years of age whenever possible, but we also wanted diabetic patients. We wanted patients with large BMI, and we wanted female patients also. So we spread it across, and that's when we noticed that there was a benefit, especially for patients with a large BMI and for females. And we're going to touch on that also, but this just gives you a little bit of a breakdown of what the clinical trials were. So on the phase 3 results, just so you know, flurpiridaz met the primary efficacy endpoint The sensitivity of PET was higher than SPEC, and the specificity was non-inferior. But on the second bullet point, this the area under the ROC curves were higher than SPEC in the overall population. So even when we say this benefits patients with a high BMI or females, it really benefits the entire population across the board. And when it came against SPEC, when it came to perfusion defect size and severity evaluation, when it came to image quality, when it came to diagnostic certainty and radiation exposure, flurpiridaz was found to be clinically, well, it was superior on that, and it was found to be clinically safe. So it made a difference. And then on the bottom here, sorry, I pressed the wrong button, but we can do that one. You can see that it has the higher image resolution and it has a higher extraction fraction. And one of the things about flurpiridaz is you have the opportunity for single dose delivery. We talked earlier about if you want to do with rubidium, you have to bring the generator, pay all this money for it. With flurpiridaz, you can do single dose. You only want to do one patient today? Not a problem. We can just deliver one dose for your patient. So you're going to have a lot of benefits with flurpiridaz once hopefully it becomes available. And let's talk about the mechanism of action. How does flurpiridaz work? So flurpiridaz targets the mitochondrial complex 1. And that's important because that makes it cardioselective. It makes it cardioselective because mitochondria make up about 20 to 30% of the myocardium. So when you do SPECT, a lot of times you'll see that there's uptake on the myocardium, but you'll see sometimes higher uptake on the liver. And then you have to wait or you have to do certain things. And sometimes it just won't go away, or you'll get some gut uptake. And let me tell you, one of the things that we noticed a while back in the field is that with patients doing gastric sleeves, gastric bypasses, patients taking, all these GLP-1s, sometimes it just sits there and they don't process it. So that becomes a challenge with SPECT. But because with flurpiridaz, it targets the mitochondrial complex, that's really not an issue. It'll target the myocardium, it targets the liver and the gut in a lot lower quantity, so you're not going to have that issue. It's advantageous in detecting myocardial blood flow. We talked about MBF and reserve. And the extraction fraction, we're going to compare it to some other PET agents available out there, but because it has a higher extraction fraction, it makes a big difference. So a lot of the questions that we get is, well, I want to go from SPECT to PET. Do we stress the patients any differently? Does anything change on the stress portion? And the stress portion really doesn't change anything. And I just did a step-by-step, but I think pretty sure most of you know this already. You're still going to be doing, if you're doing pharmacologic stress, where you're doing ragadenosine, adenoscan, dipyridamole, it's not going to change. You're still going to do it the same way. And I just put it there just for reference. We still ask the patient to do a 4-hour fast, no caffeine. If they're taking any beta blockers, channel calcium blockers, even some nitrates, they may be discontinued, but we will always say at the discretion of the physician. So, we don't make that decision. We always say let the physician make that. And, one of the most important things, communicate with your patient. That's not going to change. Let your patient know what's going to happen. If you let them know what's going to happen, they're not going to get scared. They're going to be okay. There's not going to be a lot of motion. You're not going to have a lot of artifacts. So basically, whatever you're doing for your SPECT testing right now is going to be the same for your PET CT. There's really going to be no change on that. Just make sure your patient's properly positioned. And especially if you're doing SPECT CT, you're already doing the CT portion already. So there's really going to be very little change on that. So let's talk about the different MPI tracers out there. And there's 4 MPI tracers for SPECT CT that you can use. Well, 3 technically, because 015 has not been FDA approved. It is used by some sites only for research. But what I want to point out is let's talk first about the half-life. If you look at rubidium, it has about 1.25 minutes, so it's really about 80 seconds on the half-life. And it has some advantages, it has some disadvantages. Disadvantage, you cannot do exercise. Disadvantage about rubidium, if you do a patient and rubidium does not target the mitochondrial complex like flurpiridaz does, so you're going to get some gut uptake, you're going to get some liver. So if you get some uptake with rubidium and you do the images, You get what you get, and that's it. It's an 80-second half-life. If you want to reimage, sure, you're not going to get anything. It's gone. So that's, one of the things that is going to be a little disadvantages. On water, it has a 2-minute half-life. Ammonia has about a 10-minute half-life. Some sites did try to do exercise with ammonia. It's iffy because the 10-minute half-life, by the time you get the patient back to baseline on the heart rate and everything, probably is going to be gone. But with flurpiridaz, 110 minutes. So exercise is not an issue. And exercise becomes sometimes an issue because we've had sites that they were doing PET CT and the patient would come in and they said, well, the patient needs cardiac clearance. Okay, the patient's going to have back surgery or whatever the case may be. So they send the patient for cardiac clearance and the patient comes in, and a lot of patients wait till the day before or a couple of days before for some reason, but we see that a lot. Patient comes in for the cardiac PET CT, they come in, they had caffeine. So what happened before? Well, I can't do the PET CT. So we're going to cancel the surgery, we're going to cancel the test, we're just going to have to cancel everything and start all over again. With flurpiridaz, you don't have that problem. The patient comes in and the patient says, well, I had caffeine. Well, we'll just put you on the treadmill. The patient's able to exercise. It's not a problem. So that's something that you can also use to your patient's advantage and to your advantage. If you look at the production of it, rubidium, we talked about it. You need a generator, which is very expensive. Now, I don't know how much it is. A couple of years ago when I was doing this, it was anywhere from 40 to 60,000 for every 6 weeks. So it's a pretty expensive generator. And if you're only doing 10 studies a week, it's just not feasible. But one of the things that I really want you to look at is the third one, the positron range. And we're going to go into more detail on the next stage about what positron range is, but just note that the positron range is the shorter the positron range, the better your image resolution. And you can see it right underneath it. If you look at rubidium that has a positron range of 8.6 millimeters, well, look right underneath it and look at the image resolution. It's the lowest image resolution that you can get. So you can do rubidium, but your image resolution is not going to be that good. And then if you look at flurpiridaz, because it has the shortest positron range, then it has the highest image resolution. So that's how you're able to pick up smaller defects. You can see the papillary muscle a lot clearer on the resting stage. You're going to be able to see more detail. And that's why you're able to do your MBF. You can pick up your myocardial blood flow a lot cleaner and a lot easier with flurpiridaz. And then we're going to look at the extraction fraction. And again, I'm going to pair it with the one right underneath it. If you have the higher extraction fraction, you're going to have a better perfusion defect contrast. If you look at flurpiridaz, that has a 94% extraction fraction where you have the highest perfusion defect contrast. And then if you look at rubidium, because it has the lowest myocardial extraction fraction, 65, you're going to have the lowest perfusion defect contrast. And then, it talks about, can you do exercise? Is it FDA approved? Which we already touched on, but that just gives you a better idea of the advantages of flurpiridaz. And this is what positron range is. Positron range is, PET is positrons annihilating each other, and then you get your 511 keUVs, but the positron travels a little bit before it's annihilated, before it's completely destroyed, and you get your 511 keUV on your photons. So if you look at that scale, now this is not to scale, so this is not really 1 millimeter and 9 millimeters, but it just gives you an idea. With rubidium, basically what this says is because the positron traveled about 9 millimeters, well, the positron could have originated anywhere in this area. So that's why your images are going to be a little bit blurry with rubidium. And with flurpiridaz, it's only going to travel this much compared to it, so we can get a higher image resolution on it. You can pick up better defect contrast, you get the better image resolution, you can do the better extraction, the better blood flow, and that makes a big difference. So, and then on the right, you just have, you have a little, this just was just a phantom that we had with a little defect there. And if you look at the rubidium, it looks kind of blurry. And then as you move to 015 to N13 and to flurpiridaz, you can see it a lot better. It gets clearer. There's not so much, it's not as blurry as if you look at the rubidium here. So, and that's just a phantom, but it gives you an idea of what it is. So now you're doing SPECT, and you say, well, I wonder if my software is going to work with it. Well, Basically, I'm going to tell you, the way we put it is we're agnostic when it comes to software. Whatever you have, we'll work with it. And there's the three major ones. They're currently approved for use with Flurpiridaz. You have NVIDIA 4DM. So if you're using NVIDIA 4DM for your spec, we'll be able to use it for your PET-CT. You might have to do a little upgrade on it, but you can still use it. Are you using Sirius Cyanide? No problem. We can use it. Or are you using Emory Toolbox, Centromed? We can work with that. And they'll recognize Flurpiridaz. You can do your MBF. You can do your processing. You can export your MBF. You can do all that. So we're pretty much agnostic with whatever software you have. We'll work with it, and we work with them. So, it's been already approved for use with them. And now let's just talk about the advantages. We talked about them, but I just want to put them together. I want to, just do a kind of wrap it up here. What are the advantages of Flurpiridaz compared to rubidium or any other agent out there? Well, the biggest one is your diagnostic confidence. Why? Because you're going to have the highest resolution. Your image resolution is going to be the best because you have the short positron range. You're going to have the prolonged half-life, and you're going to have that high extraction rate. So that's going to give you a lot more diagnostic confidence. You can detect subtle defects, right? We talked about the size of defects. You can detect, 4 millimeters, 6 millimeters versus 10 to 15 millimeters with SPEC. You can do absolute perfusion and quantification. It's a big advantage. It's highly reliable. And then injection of lower radioactivity, which we talked about, right? It is a higher energy level, but when you inject the patient, and kind of to give you an idea, let's talk about how much you give your patients if you're doing SPECT. An average lab gives patients for a SPECT stress test, 40 millicuries, right? 10 and 30. So you're giving about 40 millicuries. If you're doing rubidium, it's about the same because we usually do 20 and 20, right? 20 millicuries for rest, 20 millicuries for stress. With Flurpiridaz, we give 2.5 to 3 millicuries for rest, which is a lot less than what the other modalities are doing because it has a higher extraction rate. And then for stress, if you're doing pharmacologic, we do 6 to 6.5. And if you do an exercise, 9 to 9.5. So really, under no circumstance are you going to give a patient more than 13 millicuries. And that makes a difference. If you're giving 40 millicuries versus 13 millicuries for total, that's where you're going to have lower radioactivity for the patient. You can do delayed images, and you can do your exercise stress, and you can have unit dose delivery, which we talked about. No need to buy the generator. Just go ahead. If you want to do 5 patients, then we'll deliver the doses for 5 patients. If you don't want to do any that day, then you don't get any doses that day. You can order whatever you want. And then we talked about a longer half-life, but what does that mean for you and for your patient? Yeah, it does have a 110-minute half-life, but what does that mean? Well, that means we can produce it, if you have regional cyclotrons, which you guys have in Puerto Rico from what I understand. And like we talked about, you can use it in conjunction with the treadmill exercise, and you can do a flexible imaging window. And what we mean by that is, let's say you put a patient on the treadmill because you want to do an exercise PET-CT. You inject the patient, you're done with the stress, now you're recovering the patient, you want to bring everything to baseline. But because for whatever reason, you decided to put a resting patient while we're doing this. Not a problem. If the patient needs to wait 30 minutes, an hour before the imaging, it's not a problem. You have a window there. You don't have to hurry and rush and say, no, you can't put anybody on the camera. You can have more flexibility to do your patients. So that's one of the biggest advantages. And then, we say you have high myocardial extraction fraction. And if you look on the right of that, it gives you an idea of water, Flurpiridaz, ammonia, and rubidium. And it gives you accurate detection of mild perfusion defects and the robust quantitation of myocardial blood flow. Radiation safety, right? Especially with labs that are doing SPEC, they always have questions. Radiation safety. And honestly, I'm going to tell you, you're already doing what you need to be doing. We all remember, time, shielding, and distance. It doesn't change. And I just put it here in context, and I'm going to go over it lightly, but you're already doing 95% of it. Whenever we go to a site because the patients want to go live or something, what I always tell them is you're already doing 95% of it, whether it's the stress portion, whether it's radiation safety, whether it's reading the studies, whether you're doing processing, you are doing about 95% of it. We're not reinventing the wheel. It's a smooth transition. it doesn't change. Your radiation safety is not going to change. You want to spend as little time as possible near the radioactive source or a patient that's been injected. Is the case for SPECT, is the same case for PET-CT. Your distance, you want to be as far away from the radiation source, whether it's the syringe or the patient. Same thing you're doing with SPECT, you're going to do with PET-CT. And then physical shielding. If you're already doing, and I hope everybody's doing the syringe shield, the case to carry the dose, is the same thing. It's seriously the same thing. You don't have to reinvent the wheel. It's going to be a smooth transition. It's just keep remembering time, shielding, and distance, which we already know. And of course, Alera, right? As low as reasonably achievable. I mean, that's basic radiation safety is not going to change. And this is just touching on that. So just so you know, if you're doing FDG already, it's going to be the same process that you're doing right now for radiation safety because it's F18. If you're already doing FDG, it's not going to be a big change on it.